right, hello everyone, this is Dr. Pruett. Today we're going to be talking about headaches. There are a lot of causes of headaches, and I definitely don't expect you to be able to diagnose each one, but hopefully by the end of this lecture, you'll kind of have some categories that you can break them into and a good approach to things that you're going to ask this patient and how you're going to do your exam and your treatment. So as I start to think about different types of headaches, there are headaches that are fairly benign and are very common, and those are called primary headaches. And those are your migraine headaches, your tension headaches, and your cluster headaches. These are very painful for patients, but they're not anything dangerous typically, as opposed to your secondary headaches, which are caused by something else, either infection or trauma or vascular emergencies, sometimes tumor or cerebral edema or toxicity. And so I find that with headaches, more so than some other complaints, your history and your physical are really going to help you figure out what's going on with this patient. So take your time, ask a lot of questions, and try to figure out what is happening. So things I like to ask when I'm getting a history from a patient that's complaining of headache, I ask about recent head trauma. And when I say recent, that doesn't just mean like in the last couple of hours, but it really means over the last couple of days, especially with elderly patient or alcoholic patients. Blood can accumulate inside the skull and not become a problem until there's so much that it's been there for a couple of days. And so I go back, maybe even within the last week, to ask about any recent head trauma. And this won't always be visible on your exam either, so make sure you're asking if they've had any recent falls where they hit their head. I ask about history of cancer. Whether it's in remission or not, a history of cancer is always important when we're talking about a patient with a headache. Any history of bleeding or clotting disorders. If they're prone to clot in their legs or the lungs, they're also prone to clot in their brain. So I ask if they're on blood thinners, and I ask if they have any history of clotting before. And then any associated symptoms. So things that are very important would be to ask about recent fevers. Fever plus headache always equals meningitis until proven otherwise. Any neck stiffness, any changes in vision, or new neurological symptoms. All of those would be big red flags that make me stop and think, what do I need to do about my PPE? How do I need to assess this patient and treat them? And should I start to expedite my treatment based on any of the answers to these questions? And then another thing I like to ask about is onset and progression of pain. If it's a sudden onset of the worst headache of my life, that's going to be a headache that I take a lot more seriously than someone who has migraines and this feels like their previous migraine and they just want help to make the pain go away. As you're evaluating headache, as always, vital signs are vital, so make sure you're getting a good set of vital signs, sometimes at least one or two sets. And then if it's appropriate, make sure you're considering stroke as one of the potential causes of headache. So do your Cincinnati stroke scale in the right clinical setting. EMS treatment of headache. Make sure you're starting with airway and oxygen if indicated. I've seen plenty of patients whose chief complaint is headache, and they're having a headache because they're anemic. And so they might also be hypoxic or bleeding, so you can ask about that. Give them oxygen if they need it. Pain control, I'm very stingy with my narcotics and anyone who's complaining of a headache. One, I don't want to change their mental status, but two, there's very few headaches that actually need a narcotic. I would stay away from NSAIDs because on the off chance that this is some sort of intracranial hemorrhage, you don't want to make that worse by thinning their blood. So really your options for headache are going to be Tylenol and ketamine. And remember, ketamine is a Albuquerque ambulance skill only at this point. If they're having nausea or vomiting with their headache, which is very frequent, you can give antiemetics. Don't forget that you've got the inhaled isopropyl alcohol as a trick up your sleeve to help with their nausea until you get their IV going. And then sometimes just IV fluids will help with pain too. So as we start to talk about the primary headaches or the more benign headaches, one of the most frequent ones that I see in the emergency room is migraines. This tends to be way more common in females than males. Typically pretty younger age, anywhere from teenager to females in their 40s. It's a throbbing kind of pain. And typically this patient will be able to tell you that they've had these headaches before, and this usually they have a constellation of symptoms that's typical for them. So nausea, vomiting, sometimes very sensitive to light, very sensitive to sound, Maybe they want to just sleep in a dark room. Sometimes there's an aura with this. And with these patients, I tend to ask if they've had headaches before and how this actually compares to the headaches they've had in the past. Tension headaches are another very common type of headache. This can be due to either positioning of the head or some kind of tension in the muscles of the neck or the cranium, and they'll describe a tight band-like squeezing kind of pain on both sides of the head, and sometimes it's tender to the touch. Typically, this will get better with anti-inflammatories or Tylenol or ketamine, or even just a little bit of fluid and relaxation. Cluster headaches are kind of interesting. This is most common in males ages 20 to 40 who have a history of smoking. And what this is, it's a very unique unilateral kind of headache that involves the face. And what you'll see is just a one-sided facial involvement of sweating, red, watery eye, runny nose, facial flushing just on one side, but it's very painful. And it tends to come in clusters, and the clusters will last a couple minutes, but there'll be multiple of them throughout the day, and they can be very severe. And so if it looks like a stroke, treat it like a stroke, because it's not up to you to diagnose this in the field. So don't hesitate to do your Cincinnati and call a stroke alert if you need to. But at the same time, realize that this kind of headache does exist and is very painful. And interestingly, the best treatment for this is just to give some oxygen, and it tends to be relieved by high flow oxygen. So if you have this patient, if you're worried about stroke, treat it like a stroke. We always treat it like it's the worst thing it could possibly be until we know that it's not. But in the meantime, if you have the patient with this kind of presentation, give them some oxygen and see if you can help them feel better. As we move on to the more secondary causes of headaches, one of the first things we think about is infectious causes. And this can be caused by viruses or bacteria or even fungus. One of the most common types of infections that causes a headache is sinusitis. And this is fluid that builds up in the sinus cavities behind and around the eyes. And usually this patient will complain of facial pain, either in their cheeks or in their forehead. They'll typically have a headache. I ask them too if their teeth hurt. A lot of times patients with a sinus infection will have sore teeth and it hurts to chew. Usually they'll tell you that they've had an upper respiratory infection for about a week or 10 days. And as that congestion tends to build up in the sinuses, if it's there for a prolonged period of time, it can become infected. And as it becomes infected, these patients will have a worsening headache. Sometimes they'll have a fever and a really tender face. Really, in the pre-hospital setting, the only treatment is supportive care, but this is a patient that will likely need antibiotics from the hospital. Meningitis is one of the big feared headaches that you'll hear talked about very frequently, and this is fever plus headache. Anytime you have a patient who's complaining of a fever and headache together, it's meningitis until proven otherwise. There's 2 or 3 different types of meningitis. There's viral, bacterial, and fungal. And all this means is that somehow some pathogen has gotten inside the lining of the brain and is causing infection around the brain. This can, if it's very serious, cause altered mental status. The one that has a super high mortality is bacterial meningitis, and this can occur anywhere from newborn infants all the way to the elderly. The mortality is incredibly high. It can cause brain damage, hearing loss, as long-term sequelae if these patients actually survive the initial insult. What you'll typically see is a patient who's been complaining of headache with fever, stiff neck, and if it's bacterial meningitis, they tend to look incredibly sick, like almost on the verge of death. They tend to be pretty septic. They're very altered, if not comatose. And sometimes one of the things that you will see that can help you diagnose this is a very characteristic purple, deep purple rash. It's called purpura fulminans. And if you see this on your patient who is unresponsive and febrile with a history of a headache, you need to make sure that you're using your full PPE. That includes an N95, eye shields, and gowns to protect yourself from potential bacterial meningitis. This is a contagious entity. The hospital will notify you if you've been exposed to this if it's diagnosed later. But have a low threshold to use your PPE if you have this patient with a history of headache who's unresponsive and comatose with a rash that looks like this. These patients may present in septic shock, but they also may present with seizures as well. Another kind of invader that can cause an infectious type headache is a tick. it will cause fever with headache. Typically, these patients will have joint pain and a rash as well. So I do ask about recent travel or recent like camping trips or expeditions into the woods where they may have been exposed to ticks, or even if they have found a tick on themselves and removed it over the last week or 10 days. Sometimes these bites cause infections and do lead to headaches and bad joint pains. These patients typically won't look as sick as your meningitis patients, but they will complain of a bad headache and fever. Moving on to our traumatic causes of headache, one of the most common types of things we see in the field is a subdural hemorrhage. And what happens is in our patients who are high risk, whether they're elderly or alcoholic, as we get older or as alcoholics continue to drink, the brain actually physically shrinks. And when they fall, the brain can literally shake inside the skull, and there's a shearing force against some of the veins inside the head, and it can cause bleeding as those vessels rupture. And for a time, the patient tolerates this very well because there's room for the blood to accumulate. As there continues to be bleeding around the brain, there is less and less space for that to occupy, and it starts to push on the brain. And that's when we start to see the effects. So blood accumulates slowly, but make sure you're asking your patients about recent falls, especially if they're anticoagulated, because they are going to be more prone to bleed. And this can be a day or two after the fall. But it'll typically present with a worsening headache and progressively worsening mental status as time goes on. A lot of times in our trauma patients too, we see a traumatic subarachnoid hemorrhage. And again, this is just a venous shear injury. It typically happens at the bottom of the brain, and blood will track in and out of the sulci. Rarely requires surgery and usually gets better on its own in a traumatic setting. And it's not all patients who fall and hit their head actually have bleeding. That's the thing that we worry about. But some patients just sustain concussions. And another word for that would be a traumatic brain injury. These patients will present with headaches. It hurts. Sometimes they'll be dizzy or confused. They'll have persistent nausea. Sometimes they'll have vision changes, difficulty concentrating. This is a very common presentation, especially I see it a lot in our pediatric emergency department with our young athletes who fall and hit their head. Important to tell these patients is that they could have bleeding on the brain, so they do need to go to the hospital to be evaluated for that. But concussion symptoms can last for 1 or 2 months after the original injury. And so it's important for these patients. Usually ibuprofen helps with this. It's important for them to stay hydrated and get as much rest as they possibly can and help that brain to heal. And that should shorten the time for those post-concussive symptoms. There's vascular causes of headaches as well. There's both an arterial and a venous blood supply to the brain that can have potential problems. One of those that is a life-threatening kind of hemorrhage is a spontaneous subarachnoid hemorrhage, and this is usually caused by an aneurysm. Most patients have no idea that they have a blood vessel that's got a weakness in the wall, and sometimes for whatever reason, this weakness in the vessel wall will just burst and will cause the patient pretty instantly to have a very severe sudden onset of a headache, and they go very quickly from a severe headache to unresponsive. And very frequently, these patients can die. There's a very high mortality unless it's caught early. So if you have a patient who has called you to assess them and get them to the hospital that tells you they had a sudden onset, worst headache of their life with nausea and vomiting and progressively worsening mental status, you need to take that very seriously. And they need to get to someone who has a neurosurgeon who can fix that aneurysm and stop that bleeding before it becomes fatal. This tends to happen, unfortunately, in patients who are less than 50 years old. So very young patients with very severe headaches. Like I said, the mortality can approach 40% if it's not recognized early and treated appropriately. Another thing to remember with these patients, if they do say they have a sudden onset of the worst headache of their life, blood in the brain is very irritating to the meninges and the nerves surrounding the brain. And so frequently these patients will present with neck pain as well, because that stiff neck, that meningitic kind of sign when they have an infection around the brain. The same thing can happen when blood is around the brain too, so ask them if their neck hurts. Temporal arteritis tends to happen in elderly females. This is an inflammation in a blood vessel, not necessarily on the inside of the skull, but on the outside of the skull. And it can cause a very severe throbbing headache right over that vessel. It can cause jaw pain depending on which area of the vessel is involved, and it's actually tender to the touch. This inflammation can cause flu-like symptoms, so your patient may complain of fever or body aches or chills. And sometimes if it's in one of the arteries that supplies near the eye, it can cause vision changes as well. Again, this tends to be females who are older than the age of 50, usually in their 70s. And important thing to remember here is they're at increased risk of stroke. So not a lot to do for this pain other than get them to the hospital and let the hospital figure it out. But something to think about when you're asking your patient about headache, ask them if it's located on the surface of their face or like deep inside their head. Trigeminal neuralgia is another kind of headache that causes more facial pain than intracranial pain, and this is actually a nerve problem that causes severe, sharp, kind of electrical pain across the face. And this is usually made worse by things that touch the face, so like chewing or talking or brushing teeth or combing hair or any kind of touch on the face. This is I think of a nerve that's kind of in overdrive and is firing too much. It just becomes very painful. And this can be seen in patients with multiple sclerosis or sometimes even an aneurysm or some sort of intracranial nerve pain with a intracranial mass that's pushing on this nerve and making it more prone to be painful. Again, not something that you're going to diagnose in the field, just something to know about and realize exists. Venous sinus thrombosis is actually a blood clot, but it's not an arterial blood clot like you would normally think about with a stroke. It's a blood clot in a vein. Your same patients who are prone to stroke, though, or prone to blood clots anywhere, are still prone to venous sinus thrombosis as well. So I tend to ask if they have any clotting history, whether it's in their legs or their lungs, and all the same clotting factors that we know about. We know that smoking increases your risk for clotting, increased estrogen, so any recent pregnancies or current pregnancies, any recent infection, any recent trauma, all those things are going to increase the likelihood that patients are prone to clotting. And this kind of clot will typically present with a pretty bad headache. Sometimes it'll have vision changes, usually nausea and vomiting. Can cause stroke-like symptoms depending on how swollen it's getting and which area of the brain it's pressing on, or may not cause seizures as well. Again, not your job to diagnose this in the field, but something to know that it does exist. And don't forget to ask your questions in your patient history about their probability of clotting. Cervical artery dissection or vertebral artery dissection is another common cause of headaches. If you remember, as the aorta comes off of the heart, there's several vessels that branch off and feed the head. The big one is the carotid, and then you have the vertebral arteries kind of supplying the posterior part of the brain. If there's any kind of neck trauma or neck manipulation, typically I see this with chiropractors who've been kind of aggressively manipulating people's neck. There can be a shear force on that vertebral artery and actually damage the vessel wall and sometimes cause a stroke or just damage to the vessel that leads to a pretty bad headache. So this patient will tell you that they have a headache. Sometimes it does originate in the neck. They can present with stroke-like symptoms depending on the vascular damage that's been done. And frequently, they'll see floaters or have changes in their vision as a consequence of the disrupted blood supply to the posterior part of that brain. Like I said, I've seen this a lot with chiropractors that have been a little too aggressive with people's necks. So I tell everybody I'm all for the chiropractor as long as they do their adjustments below the neck. I'm okay with that, but I've seen too many consequences of neck manipulations to think that that's safe. Another patient population to consider this in would be your young athletes, maybe football players or wrestlers, or even in car wrecks, any kind of situation where someone's neck might be twisted abruptly or put in a position that it's not normal. There can be vascular damage to the back of that head. So ask about head and neck pain. Strangulation can cause this as well, and sometimes it just happens spontaneously. There are things that can cause headaches due to intracranial pressure being increased. One of the most common things unfortunately, is a brain tumor or metastatic cancer. That's why it's important to ask your patients if they have had cancer before. Even if it's in remission, cancer can come back. And there's certain kinds of cancers that when they do come back after being in remission, they love to go to the brain. And so the most common tumors that are metastatic to the brain are melanoma, lung cancer, breast cancer, and colon cancer. So ask about cancer history and then do a good neuro exam. Ask about vision changes, ask about headaches. Headaches that are caused by tumors tend to be worse in the morning and tend to be a little bit positional. Can be associated with nausea and vomiting as well. There's another kind of cause of headache called Pseudotumor Cerebrii, and I know that's a big word, but what it really means is that there's something in the brain causing intracranial hypertension, and we don't know what it is. And this tends to be very common in obese middle-aged females. Don't know why, that's why it's called idiopathic, but it is a common presentation and sometimes needs an intervention by a neurosurgeon. So it causes a diffuse throbbing headache. Sometimes they'll present with visual disturbance. Sometimes they'll hear a ringing in their ears and causes nausea and vomiting. It can be a debilitating headache, and it tends to feel worse when they're lying down or bending over, just like we talked about with the cancer patients. When it's worse in the morning, they're lying down, or changes in position, or sometimes coughing. Anything that's going to increase the blood flow to the head will increase that pressure and make the headache worse. Again, not your job to diagnose this, but something to think about as you're evaluating your headache patient and trying to figure out which questions you want to ask them. Sometimes that pseudotumor cerebri can get so bad that those patients need a VP shunt. That's a ventriculo-peritoneal shunt, and this is that neurosurgical procedure that I was talking about. It's actually a physical drain that goes into the ventricles where that cerebrospinal fluid collects, and it literally drains the fluid from the brain into the peritoneal cavity. And it's not just the pseudotumor patients that need this. There's a lot of reasons why patients might need a VP shunt, but if you've heard of a VP shunt before, this is what it is and this is what it does. And just like any foreign body that we put into the body, it can get infected or the hardware can become disrupted. So if you have a patient with a VP shunt, make sure you're asking about infection or any recent trauma. Sometimes it can actually drain too aggressively, and that can cause headaches as well. Another interesting cause of headache is acute angle closure glaucoma. And the times I've seen this, I've actually thought it was a stroke, because your patient will be in severe pain, have nausea and vomiting, and one pupil will look very different than the other pupil. And the reason is because they're having problems with their eyes, and they won't necessarily be able to tell you that their eye hurts. Typically they'll complain of a headache, but what's happening here is it has everything to do with the angle of the eye and drainage of the fluid around the eye. And as the angle changes, what happens is there's a blockage of the fluid draining from the eye. It builds up pressure in the eye, actually behind the eye, pushes on the optic nerve, and causes a terrible headache with that dilated pupil and some vision changes. So if it looks like a stroke, still call the stroke alert, still do your Cincinnati exam and your LAMS score, but realize that sometimes acute angle closure glaucoma can cause headache as well. This tends to happen in your older patients. Another important cause of headache is pre-eclampsia. This is a pregnant female or recently pregnant female who has a blood pressure greater than 140/90 on 2 occasions during pregnancy. This can cause headache, vision changes, swelling in the leg, shortness of breath. When it becomes important for us is when it causes a seizure. Realize that eclampsia can occur up to 12 weeks after delivery. So just because the female isn't pregnant, ask her if she's had a recent delivery, because the consequences of preeclampsia can go on up to a couple months after delivery. And we treat this with Versed like you would any seizure, but if you realize that this is eclampsia and not just a run-of-the-mill seizure, make sure you're giving your magnesium as well. Your doses for Versed are anywhere from 1 to 5 milligrams IV or IO. And then for MAG, if you actually have eclampsia, it's going to be 4 grams IV over 10 minutes. Lastly, toxicity is something to think about when you're evaluating your patient who's complaining of a headache. Ask them what they've been exposed to in their environment, any vapors, anything they've been doing recently. I find that recent history before the headache started sometimes will really point you in the direction as to what's causing the headache. So ask them what they've been doing right before the headache started. over the last day or two, and you might be surprised what you find in terms of what they've been exposed to. One of the most emergent things that we need to consider in patients who are complaining of headache is carbon monoxide toxicity. These patients will typically complain of headache and flu-like symptoms. They may be dizzy, they may be confused, all the way on that spectrum to comatose and unresponsive. And this is from incompletely combusted materials. You know this. You all are firefighters and understand it very well. But make sure if you're approaching any environment where you may be exposed to these fumes as well, first you want to take care of yourself. Remove the patient from where they're being exposed to the toxin. And then if it is carbon monoxide, remember that we have the rainbow detectors on the life packs that can actually give you a carbon monoxide level, and then treat them with high flow O2 and get them to the hospital. So I know that's a whole lot of types of headaches. You're not expected to know all the types or be able to diagnose them, but hopefully it gives you an idea of what questions to ask as you're trying to troubleshoot what might be going on with your patient and as you approach them in terms of treatment and which hospital they need to get to. Don't forget to ask about the red flags, so any recent head trauma, any history of cancer, any history of bleeding or clotting disorders, any associated symptoms with the headache, and then the onset, what were they doing when it started, how quickly did it start, and how has it progressed over the course of their illness. These will all help you try to figure out what's going on with them and treat them the best way possible. Remember, for our arsenal for treatment of headaches, airway and oxygen if indicated, avoid narcotics if possible, try to go to Tylenol or ketamine if you can. Antiemetics will be very useful here, as well as IV fluids. And if you have any questions, please feel free to reach out to the 7-8 or let me know too. I'm always happy to talk about these things.